Hello, my name is Dr. Joseph Mikhael. I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation. And I want to present to you today an overview of the research that was presented at ASH 2022 in multiple myeloma that relates to health disparities. Health disparities is a critical and important topic that has really risen in its prominence over the last few years for a whole host of reasons. And the IMF is deeply committed at finding ways to reduce these health disparities. And so it's remarkable to see how much is now being presented in the research world regarding this so that we can understand these disparities better so that indeed we can reduce them. So there were about 1,000 abstracts in myeloma at ASH this year, but really no less than 30 that were explicitly dedicated to understanding and reducing the disparities that exist in multiple myeloma. There's no way I can go through every abstract in a short presentation like this, but let me just give you some highlights of, I would suggest, 7 key areas that were studied and continue to be studied to help us understand these disparities. The first of the areas is really looking at the social determinants of health. And when we look at a disparity in a disease like multiple myeloma, we can't just rush right to myeloma as it were. We have to look at the bigger picture. What's happening in the greater society at large with regards to things like systemic racism, the way the healthcare system is built, the way a society is essentially structured, and indeed the socioeconomic status of individuals. You know, it's hard to talk to someone about their myeloma treatment if their stomach is empty. And so many of these studies had looked at the influence that the social determinants of health have, not just on general health, but indeed our multiple myeloma, looking at things like social vulnerability index and how patients with reduced socioeconomic status are less likely to have an autologous stem cell transplant, are less likely to receive the therapies that are necessary. And it reminds us that as we address health disparities, we not just look at it from a very small world of what's going on exactly in myeloma, but the bigger picture. Similarly, theme number 2, I have 7 themes for you today. Theme number 2 are insurance issues. And again, instead of just jumping into this drug versus that drug, we really need to look at the insurance system. And sure enough, sadly, we saw that African-American patients, for example, were much more likely to be uninsured or have Medicaid or Medicaid insurance and or less likely to have private insurance. And this clearly influences access and influences outcomes. We saw that there was a tremendous disparity in Part D enrollment and the impact that might have on oral therapies, knowing, of course, that in myeloma, we use a lot of oral therapies. So being able to, as best we can, leverage the insurance system and facilitate people's insurance coverage and the optimal use of that coverage is going to be very important to reducing that disparity. Issue number 3, and this is often the biggest issue, is access. Access. We saw that there were a whole series of barriers to access to therapy, trust within the system. As we mentioned, even to some degree earlier, the socioeconomic status, but not just that, but specifically, are we providing transportation for patients? Has education been optimal so people can understand the therapies that are being offered to them? These are very critical areas at a community and an individual patient level that can heavily influence someone's access to therapy. One of the studies had particularly said that what's critical for the medical community is to deepen community engagement and to deepen community education, which interestingly is very much what we're trying to do with the IMF and what we call our Empower program, M-Power, standing for Myeloma Power, as we empower patients and communities to change the course of myeloma by understanding that myeloma is twice as common in the African-American population, that outcomes are literally half of that of white patients, that myeloma is diagnosed younger in the Hispanic and Latinx population, and that there's reduced access to therapies in patients of that ethnic background. And so it's important for us to understand how access really influences the way patients do. And indeed, we have research now that demonstrates to us unequivocally that patients have less access to what I often call the 4 T's. Triplets or 3 drug combinations, transplants, autologous stem cell transplant, trials or clinical trials, and now more recently, CAR T cell therapy. So that is really important in improving these disparities, as increasing access to therapies. So we've talked a bit about social determinants of health. We've talked about the insurance system and access. Well, now let's talk about number 4, biology. We saw that there is a different biology. We know, of course, historically that you are for example, African Americans are less likely to have certain high-risk features like p53 deletion, or more likely to have a translocation 1114. Hispanic patients may well be the youngest patients on average diagnosed with multiple myeloma. But the biology goes beyond that greater biology. Even individually, greater studies have shown that, for example, extramedullary disease may be more common in the Hispanic population. When we look at patients going to CAR T-cell therapies and we measure their baseline immunologic levels, things like that may predict cytokine release syndrome, like their CRP levels and albumin levels, that those are different within the African American community than they are within the Caucasian community. So lots of different things that may help us understand that. For example, deletion 1p may be 2.5 times as common within the Hispanic population. So understanding these differences do have an impact later on, but the biology of myeloma is different in different race and ethnicities, and it's important for us to know that. Then this brings us to subject number 5, which is adverse events. And that can be different based on race and ethnicity. We know, for example, unfortunately, neuropathy is more common within the African-American population after receiving bortezomib-based therapy. We know that from CAR T studies, African-American patients and Hispanic patients are more likely to have cytokine release syndrome and have longer hospitalizations. And there was even a trend, unfortunately, that Hispanic patients may have reduced response to CAR T-cell therapies. And so when we look at what we call treatment emergent adverse events, those adverse events that happen on therapy that may actually lead to discontinuation, those can actually be higher in patients with certain ethnicities and races. And specifically, we saw this with quadruplet therapy with African-American patients more likely to experience adverse events. Which brings me to topic number 5, which is outcomes. And sadly, we've known historically, as I mentioned before, that survival of African-American patients with myeloma is typically half that of Caucasians. But we did see encouragingly this year at ASH a whole series of outcome studies looking at longer-term follow-ups through SEER databases and others, that gap is beginning to shrink, that we are seeing, thankfully, improved response rates, some degree of improved access that's resulting in similar survival outcomes. Now, we know that survival actually should even be better, for example, within the African-American community, because in certain areas, when given the same therapy, the outcomes have been the same, if not better, like within the VA system. But we're definitely seeing now improvements both in non-Hispanic Black patients and in Hispanic patients to improving survival, but has still not reached that continuing improving survival that we see in the myeloma community at large. Lastly, and perhaps I always think, perhaps most importantly, number 7, is we saw various studies looking at the importance of communication. Indeed, my own abstract, we had looked at a quality initiative of looking at the differences between how patients and their providers felt about how successful their treatment regimen was going, and the differences between patients in that, whether or not they were of African American descent or of European descent. And then implementing a program to actually facilitate that communication between the providers and patients. Understanding unconscious bias, understanding the importance of culturally sensitive care. And this was, I think, very important, not only because I was involved in the work, but it does speak to what we as clinicians can do every day in the clinic to listen to our patients more carefully, to understand their concerns, to understand their background, to be sensitive to it and appreciate how certain therapies can be applied in that individual situation, and to advocate as best we can that our patients receive the best therapies possible. Building that trust is absolutely fundamental, as fundamental across the board if we're going to help reduce health disparities. So much going on at ASH this year in health disparities. I'm encouraged to see that there's a greater interest in the field at large. I'm encouraged to see that we see signs of improvement, but there's still a tremendous amount of work to do. And you can always learn more about what we're doing at the IMF, of course, at myeloma.org, and specifically empower.myeloma.org. Thank you so much.